This on. All right, can you guys hear me now? Yeah, good. So it's a pleasure being here. We had a nice evening last night going through a different topic, but today we're going to talk about myocarditis in children in the current era, which may or may not be the same information you've been taught in medical school or during the course of your training. No disclosures. So myocarditis is one of the many inflammatory heart diseases, and I've listed 4 such types. Rheumatic fever, from a worldwide perspective, probably the most common inflammatory heart disease. Myocarditis, which in childhood is generally a viral-related disorder. Pericarditis, with or without myocarditis, so myopericarditis or pericarditis by itself, another inflammatory problem. And then if you take care of patients with heart transplantation, transplant rejection is another inflammatory disorder. I'm going to talk mostly about myocarditis, but I'm going to use transplant rejection as a similar disorder, and I'll show you why that might be as we go along. So I like to start with definitions. Myocarditis is an inflammatory process affecting the heart, causes ventricular dysfunction, so it's a pump problem. The inflammation can involve the cardiomyocytes, the heart muscle cells themselves, the interstitium, the vascular elements, pericardium, and in pediatrics is almost always acute, whereas on the adult side, it's most commonly a chronic process. This can be seen at all ages, including newborns. So if mom has viral disease at the end of pregnancy, it's not uncommon to infect the placenta, and then the child gets infected and can come out already with myocarditis. And it certainly can be seen throughout childhood and into adulthood. Typically, in the pediatric patient, usually you make the diagnosis because they have signs of heart failure. They may have cardiovascular collapse, come into the emergency department needing resuscitation. They may have an arrhythmic presentation, either slow heart or fast heart, with either a bradycardic AV block kind of a problem or ventricular tachyarrhythmia. So it's a high-risk acquired form of disease. Lots of different etiologies, infectious and non-infectious. I've highlighted viral here. Because that's really what we see most commonly in pediatrics. At St. Jude, it would be the combination of viral and cardiotoxins that we see most of. But if you take all of children, viral disease is really the most common. So I'm going to start with a case. This is a 6-week-old boy who was in moderate distress, 3-day history of progressive shortness of breath, was sweaty, pale, cool for about the last 24 hours based on the parent's history, wasn't eating very well and had poor urine output for the last 24 hours, was very irritable for the last couple of days and had been vomiting. So was pretty dry, looked pasty and pale, not feeling very well and breathing fast. So brought to the emergency department, we're on exam, child was pale, had poor perfusion, tachycardia and tachypnea, was diaphoretic and cool, had a big liver, weak pulses, and distant heart tones. On cardiovascular exam, had a gallop rhythm and a grade 2 apical systolic long murmur consistent with mitral regurgitation. So in the ED, between the ED physicians and the consulting cardiologists, a chest X-ray was performed, an electrocardiogram, a CBC, and chemistries. The cardiologist suggested a B-type natriuretic peptide, or BNP, and a troponin. There were cultures sent from the blood and from urine and other peripheral sites. Viral serologies were sent, and an echocardiogram was requested. So from a diagnostic imaging standpoint, here's a chest X-ray, and what you'll notice here is that this is a gigantic heart. The CT ratio is about 80%, very big. You can see the pulmonary vascular markings are abnormal, consistent with pulmonary edema. So cardiomegaly to the nth degree. If you don't notice this kind of cardiomegaly, you're not going to ever notice cardiomegaly. This is a big heart. On echocardiography, we see here, so just to point out the various features of the echo, this is a so-called parasternal long axis view. Here's the left atrium here. This colored stuff is mitral regurgitation. The left ventricle is quite big. If you measure from end to end, it's very large. Here's the aorta, and the right ventricle would be up here being squashed. And here's a pericardial effusion. So this is at least pericarditis with a dilated cardiomyopathy, etiology unknown at this point, but you have to start thinking about myopericarditis as a potential diagnosis here. This is a so-called short axis view. The black here is the chamber of the LV. Here's the interventricular septum and the free wall and the papillary muscles. And in real time, not moving very well, demonstrated here in an M mode where the down here is moving. This is systole, but the septum is doing not much. So dilated LV, effusion, mitral regurgitation, dilated LV, and LV dysfunction. Here's an electrocardiogram, and I'm going to point out a few things. In leads 1 and AVL, we have Q waves. We have ST segment abnormalities across the board. If this was an adult, you'd be worried about myocardial injury or myocardial infarction. There's also fairly low voltage out here. And so an ischemic form of some sort of underlying cardiac problem. And so this is pointing to the Q waves and the ST segment abnormalities. So you have a dilated, poorly functioning heart with heart failure and an abnormal electrocardiogram. So the chest x-ray, cardiomegaly, increased pulmonary vascular markings, low voltage QRS, ischemic changes, an echo that shows what I just mentioned. CBC had mild anemia. Chemistries was hyponatremic. Creatinine was a bit high for a 6-week-old and had low bicarb, so it was acidotic. BNP was sent. It came back, and this is a straightforward BNP. It's not an NT-proBNP. Less than 200, somewhere between 100 and 200 is the high end of normal, so 1400 is very abnormal. And this is a pretty good biomarker for heart failure. If you had purely respiratory failure, your BNP would be closer to normal. In addition, the troponin was elevated, suggesting that the heart muscle was breaking down in addition, so you had troponin leak. Peripheral cultures and serologies were sent, but ultimately were negative, which is a common outcome when you're trying to work these patients up. Second case, the opposite end of the spectrum for us in pediatrics, is a 16-year-old boy who presented with dyspnea on exertion, chest pain, and syncope that just occurred. He had a history of a URI about 6 weeks prior, was fatigued for the past several weeks, had some intermittent nausea, vomiting, and abdominal pain for a couple of weeks, dyspnea on exertion, orthopnea while sleeping for a week or two, was lightheaded and dizzy, and developed syncope. In the emergency department, was pale and short of breath at rest, was lethargic, tachycardia with heart rates in the 130s at rest, was mildly hypotensive with blood pressure systolic in the 90s, had a big liver, thready pulses, distant heart tones, a gallop, and again, a mitral regurgitation murmur. So the chest x-ray was performed. Again, it showed cardiomegaly and increased pulmonary vascular markings. The electrocardiogram, again, was low voltage QRS with sinus tachycardia. And the echocardiogram is demonstrated here, which you could see that this ventricle isn't squeezing very well. And if you look closely, there's going to be this swirling white stuff in there. And that swirling white stuff we call smoke, which is that there's no ejection of blood out to the body. So you could see why the heart's going to be big and you're going to be in heart failure. Classic feature of a dilated cardiomyopathy, but you still don't know what the underlying etiology is. Could it be genetic? What is it? So we already went through these findings, but what do you end up doing when you have these features? These are signs of heart failure. Again, heart failure findings, troponin elevated as well. So this particular patient was taken to the heart catheterization laboratory, and a biopsy was performed along with cultures. So this is the way we do biopsies. You could come in from the SVC or the IVC with a bioptome, which is a catheter that at the end of which has basically forceps made out of metal that when you push it up against the wall of the heart will take a approximately 2 millimeter piece of tissue. You then pull it out of the body, and that's your biopsy. And you usually do somewhere between 5 and 7 biopsies. So the risk here in a big dilated dead heart that's very thin-walled is you could push the metal right through the heart. Perforating the heart that's not working very well is not very good form. Your patient is not likely to do well if you do that. So a lot of patients don't get biopsies because their risk is too high, particularly if they're young kids. In this particular case, on the cath, the RV and LV end diastolic pressure was elevated, consistent with what you see in heart failure. There was low cardiac output. When you put the catheter in, you ended up with ventricular tachycardia. And then when you did the biopsy, instead of pulling out these 2 millimeter circular pieces of muscle, you actually were pulling out strips of tissue, meaning that the heart muscle was really in trouble. Under the microscope, it looked like this. All of the blue stuff, that's inflammatory infiltrate, that's lymphocytic infiltrate. The heart muscle cells demonstrated here don't look quite healthy. They're all in the process of dying off. Cultures of the heart, cultures of the periphery, almost never show the virus. The reason that the blood cultures and urine cultures don't show it is because the virus, the original infection, was 6 weeks ago. It's not hanging around. But the DNA or RNA is hanging around, and so with the invention of polymerase chain reaction, basically a molecular Xerox machine, we can see what nucleic acid is in the heart muscle, and we could target viruses, specific viral genomes, and figure that out. And we've been doing that for about the last 20 years or so. So myocardial PCR for viruses, peripheral cultures, and serology were sent. These were all negative. The PCR, as I'll show you, was positive. So if you're going to take a biopsy, you probably need to know what you're going to be looking for. And so in the 1980s, the so-called Dallas criteria was put together for biopsy specimens. The Dallas criteria is named such because it was a bunch of pathologists interested in the heart that met in Dallas, Texas, to come up with these diagnostic criteria. This was done during an era when COXSACKIE virus was considered the main player in viral myocarditis. And they basically broke it down into 2 types: active myocarditis, where the presence of an inflammatory infiltrate under the microscope in the myocardium demonstrated necrosis or breakdown of the heart muscle cells, degeneration of adjacent myocytes. That wasn't what looked like ischemia in the adult world. And the coronary arteries were normal in these patients. Excuse me. Borderline myocarditis, there's infiltrate, but there's no necrosis, there's no degeneration, there's no fibrosis typically. So there are a number of different diagnostic criteria, one of which is the World Health Organization criteria, where they broke it down into further. And they were very specific about how many white cells per field that you were going to see, whether or not you had fibrosis or not. And that was the differentiator between acute or active myocarditis and the chronic forms versus none. And that's demonstrated here with the different approaches. Extensive infiltrate here with lymphocytes associated with breakdown. You can see these cardiomyocytes are dying. These are marked for T lymphocytes and macrophages, and so this would, in the WHO approach, would be diagnostic of myocarditis. But you need all of those. In the US, we really mostly use the straightforward microscopic studies. Here is what normal myocardium looks like, depending on what it is you stain it for, versus borderline, mild, and severe disease. All of this other stuff really isn't going to matter. I mean, when you see this or this, you're going to make the diagnosis. From a CAS standpoint, there was increase in RV and LV diastolic pressure, the VT I mentioned, and endomyocardial biopsy, and the PCR. So here's what polymerase chain reaction in this era looked like. Right here, we're looking at parvoviral PCR, and over here is. Oh, you're not seeing it. Oh, who knew? Thank you. I'm not sure. Let's see. Where's the pointer on here on the side? Top. Okay, great. Thanks. So what you're seeing here is. So this is just a marker for, so we know what size the band is. This is a positive control. So this is what, in this case, parvovirus needs to look like. So this is where the band lives. It's this big. You can see a negative, so negative should be negative. There shouldn't be anything in that row. And here's a positive case. And you can see here that that band and that band are exactly matching. To prove that it doesn't just match in size and be otherwise not the same, we can then use some other material. This is a radioactive probe that is specific for parvovirus. It lights up the positive control as well as the patient sample, and so you know for sure that it's consistent with parvovirus in the heart. Parvovirus in the heart became a major player in viral myocarditis in the 2000s. Before that, it was adenovirus, and before that, it was Coxsackie virus or the enteroviruses. Here's a listing of the various viruses that have been identified associated with myocarditis, with parvo B19 being a late player, and HHV6 and others being added to the list. Every decade, there's a change in what viruses are the main players, and we're switching out of parvoviral era back into Coxsackie and Epstein-Barr virus at the moment. Here's another case, which is sort of interesting, and the less young people in the room will potentially be intrigued with this one. So in this particular one, we're looking at whether or not the individual has CMV in the heart or adenovirus in the heart. And this was in the early to mid-90s that this study was done. And at that time, CMV was still thought to be a considerable player in pediatric patients. This was one unknown patient, and the rest were known patients. So these are the 4 patients over here. Here's your positive control and your negative control. And you can see the positive control for CMV is positive, the negative control is negative, as are all the patients. So no CMV in the heart muscle. Here's for adenovirus, a different size. Here's your size marker, positive control, negative control. And here's your 4 patients. This patient is definitely positive. And this patient out here is harder to see, but is mildly positive. So this patient, RL, is positive. And on repeat study over and over with different parts of the heart, because we had a whole piece of heart that was sent to us from somewhere else, and that somewhere else was Boston. And this came in a formalin bucket, basically, by mail, with just RL written on it. This turned out to be Reggie Lewis. You guys know who Reggie Lewis used to be? He was the captain of the Boston Celtics, who was supposedly died from cocaine, but they never actually found cocaine for a good reason. He had adenoviral myocarditis, which is what he died from, and so we made that diagnosis. Here's a Coxsackie viral study. This was done in that baby, that 6-week-old that I mentioned earlier. This is his case. So we got a fresh frozen biopsy right out of the cath lab. Here's the positive control and the negative control over here. Here's a biopsy. Here's blood. You can see that it's very positive in the heart, negative in the blood, just like you'd expect. And so this individual died of Coxsackie viral myocarditis. Many months later, the question was asked, and this is very, very early in the use of polymerase chain reaction. And it was thought that you couldn't use anything other than fresh frozen biopsies because formalin and other things would basically kill off the nucleic acid. And enteroviruses like COXSACKIE are RNA viruses, and RNA viruses go away pretty fast. So the thought was that you couldn't possibly find virus in the heart for COXSACKIE, but that obviously is incorrect. So here's that same band in this individual. So currently, all of my patients that get biopsied get PCR. That hasn't caught on in a lot of places, but we use it, and I'll show you it's prognostic in its use. Here I say there's a shifting viral demographic. It went from, as I said, enterovirus or COXSACKIE virus in the 60s, 70s, and 80s to adenovirus in the 90s and parvovirus since 2000. And you can see here in 2000 and 2009, 75% were parvovirus, 22% Epstein-Barr virus, CMV very low, enterovirus is very low, and adenovirus, which used to be about 70 or 80%, was now down to nearly nothing. So this is from the prior decade, the 90s, and we were doing this for free, so we got a lot of samples. These were clinically diagnosed myocarditis cases, 600 plus cases. These were dilated cardiomyopathy, etiology unknown, and then we had a bunch of controls that were autopsied and didn't have anything related to the heart. You can see that almost 40% of the samples were positive, and you can see here that in that era, adenovirus was the most common, and COXSACKIE made up the majority of the enteroviruses. Parvovirus was almost non-existent. The only reason we actually studied it was we were working with MFMs, with non-immune hydrops, and at the time, parvovirus was thought to be a major player. And so we were using the probes anyway, and so we did it and found that less than 1% were positive, and then the others were low-end players, including EBV, which now has become important again. About 20% of all the dilated cardiomyopathy cases were viral positive, and it was a split between adenovirus and enterovirus completely. And then the question comes up as to whether or not virus is in the heart of normal people. And you can see that at that point, essentially never, and we never saw a case of adenovirus in the adenoviral era. There are other biomarkers. That's now a biomarker. There are other biomarkers, and this is viral myocarditis by MR. And basically what you see here is, as I mentioned, a focal subepicardial edema in the lateral wall where the arrows are. And then this thing that we call late gadolinium enhancement, LGE, in the lateral and basal wall that demonstrates scar. So it shows scar or inflammation. In someone that you're thinking might have myocarditis, it's going to be inflammation mostly with a little bit of scar. Viral cultures, almost always negative, even in florid cases of myocarditis. Blood cultures are almost always negative for the reasons I mentioned previously. But peripheral cultures, stool in particular, may be positive, but there's really no correlation between PCR positive peripheral cultures, or blood for that matter, and what's going on at the myocardial level. Histopathology is not great because you have a high false negative rate, somewhere close to 50%, because it's a patchy problem. It's not the entire myocardium. So depending on where you take your biopsy, you may or may not be able to see abnormalities. So in the 80s, as I mentioned, COXSACKIE virus, in the 90s, parvo, in the 2000s, adenovirus, in 2000s, parvo. In Asia, for the last 25 years, hepatitis C has been considered a major player, and then COXSACKIE and EBV have come on strong in the last few years. And this just demonstrates the changes, adenovirus here, enterovirus, and parvo here, and you can see the changes over the 10-year period. Now here's a disease that used to be the most common cause of heart failure in babies. In the 70s, by far the most common cause of heart failure. And what you see here in this baby from 1970, as you can see down here by this autopsy number, all this white stuff is fibroelastosis. All of the pink stuff is myocardium. So you can see that this ventricle has a lot of this endocardial fibroelastosis. And there was a raging controversy over the years as to what caused this, because these were in newborns. There was a guy in Minnesota who did some studies on chicken, infecting the chicken that developed cardiomyopathy, and he said that this was mumps virus, because that's what would develop when he would inject mumps virus and nothing else. No other virus in chickens would cause that. Alex Natus, who at the time was the most famous pediatric cardiologist, he was the chief at Boston Children's Hospital, he said, nah, that's impossible. It's COXSACKIE virus or nothing at all. It's just something that happens. So we actually went back, now that we could do PCR, we went back to all of these specimens and did PCR on them using probes for all of the various viruses, with one addition, which was mumps virus. We had never looked before. And so we screened them for all those viruses, and lo and behold, they all had mumps. And so that guy was right, but we don't see mumps anymore, and you don't see EFE anymore. We haven't seen a case of ESE in 30 years, probably 25, 30 years. So I don't know if it's MMR or it was a shifting viral demographic or what, but we don't see it anymore. So many years later, we discovered what the cause of endocardial fibroelastosis was. Now, HIV is another player. Why don't we see HIV myocarditis much anymore? We don't see cardiomyopathy in HIV patients very much anymore. And there are probably many reasons. Maybe it's the medical therapies, maybe it's the changing demographic. Not really sure. Sorry. Welcome to my life. It turns out that some of the medications, and I think I'll show you why the medical therapy may be playing a major role. But we were part of an NIH grant, and we were doing all the biopsies for PCR. And what we noticed was that when we used probes for HIV, we never found any positive in the heart. And this was in the 90s. And so these patients had mostly adenovirus in the heart. Some of them had enterovirus. So we thought that this was mostly an immune-compromised patient who got myocarditis with the usual myocarditis-causing agents and not due to HIV itself. And we published that. But nobody ever actually came to a conclusion what the cause is. And now it's hard to study because you don't have the disease much anymore from a heart standpoint. So from a mechanistic standpoint, here's a time course where you get the acute phase where you get infected, you get some viral replication. It goes through a subacute phase where the immune response starts to take hold. You get more and more inflammatory infiltrate. And then a chronic phase where you get a dilated cardiomyopathy that may or may not be reversible. So here's a case where it was reversible in a fairly timely fashion. So here's the chest film from April. Big heart, increased pulmonary vascular markings, and in July, completely normal. And that was simply with medical therapy. Today, in a patient coming in on April 1st with that problem, who was sick and barely hanging on, they'd get an assist device put in instead of using medical therapy, and their time course tends to be shortened by that. So the immune response is important, and that's why people use steroids in these kind of patients. The problem is, as I showed you, it's a secondary response. It's not the primary problem. And you usually don't use steroids in infected patients, and so that's the tug of war. Are you using it to get rid of the symptoms, or what are you using it for? And when you look at many of these patients that are chronic, steroids don't really work very well in those patients. And so there may be some alternatives to think about, and I'll show you some of that in a minute. And so here's some of the pathophysiology associated with it. Cytokines are key players. This is really the immune response, so the second stage of the development of the disease. So there's viral entry that's important, and there are receptors that drag some of these viruses into the heart muscle. There's chronic inflammation that causes disease. There are cytoskeletal defects or protein defects that are critical to heart function. And then there's ischemia. So adenovirus and Coxsackie virus infect the cardiomyocyte, the muscle cells directly. On the other hand, parvovirus doesn't affect the cardiomyocytes. So how do they get myocarditis? Well, what they get is that they get inflammation of the endothelium, and the endothelium of the coronaries in kids are small coronaries. If you get inflammation in the coronaries, you're going to get coronary insufficiency, and these patients present with ischemia. And the myocarditis under the microscope is really a secondary inflammation to ischemic myocardium. So they all get inflammation, but for different reasons. So myocarditis in kids, very few people are biopsying, particularly small kids, because of the risk of perforating the heart. So how can you look for patients who have inflammation in their heart and do a biopsy and do it safely? And so we asked that question a long time ago, and the answer was transplant patients. They get rejection, which is inflammation. They get biopsied all the time. It's surveillance. And why not just take those samples and run PCR on every one of them, so that in that same individual, from month to month, you could tell whether or not they were positive or negative. And so negative, 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 positive, what happens before and after once they get infected? And what does medical therapy do for them? And that was the question at hand. So it turns out that COXSACKIE and adenovirus, which, as I mentioned, infect the myocardium, these stimulate inflammatory responses, particularly COXSACKIE. So the Dallas criteria, which was created in the COXSACKIE era, is all about COXSACKIE. It's actually not a very good test, which is why it only has a 50% sensitivity rate, because as the years have gone on, it's gone away from being COXSACKIE. And adenovirus causes more scar than it does inflammation. And so not a very good test for adenovirus. And as I mentioned, for parvovirus, it's not good at all because of the endothelium being affected mostly. So from a viral entry perspective, they're actually membrane-bound receptor proteins that drag the virus inside and allow infection of the cardiomyocytes directly. And so you end up with a direct cardiomyocyte disease. From the phases of injury, we went through that. This is a pictorial of that. I think I'll just skip through that and show you some of the clinical impact of viruses on the heart. Or not. Let's see. Let's go back. So you can see here the pathogen, the infection site, and the clinical consequence. You can see the enteroviruses, adenovirus, and HHV6 here, direct cardiomyocyte, interstitial cells, and infiltrating cells, and you end up with heart failure, either a diastolic or systolic disease. You can see here enteroviruses infiltrate the cells. You get a lot of inflammation. And then the endothelium can also take a beating. The problem with this particular set of pictures is that they really didn't describe much when it came to parvo specifically. Chronic inflammation is important, but this really looks at the cytoskeletal proteins. One of the key cytoskeletal proteins is the gene and protein that cause muscular dystrophy of the Duchenne or Becker type. Boys that get muscular dystrophy, 100% of whom get a dilated cardiomyopathy in their teenage and young adult years. And so we studied that, and here's a study looking at antibody to the protein at different ends of the protein. Here's normal control patients. Here's ischemic cardiomyopathy adult patients, and these are myocarditis and genetic forms of cardiomyopathy or idiopathic forms of disease. And what you see is that one portion of dystrophin is always abnormal, either completely not there or very mildly there. This is a so-called Western blot looking at the protein. This is before a VAD, a ventricular assist device. This is after. Ventricular assist device puts the heart to rest for an extended period of time. And so this is 6 weeks, beginning, and then 6 weeks later, beginning, and 6 weeks later. What you see is a normalization of dystrophin in this part of the protein in all of these patients. This young adult and this young adult completely normalized their heart on the VAD. The VADs were pulled out. They were never transplanted. This patient got an organ. They didn't know what to do. They got the organ. They transplanted this patient. This patient never really recovered and got transplanted. So as a biomarker, dystrophin seemed to be important, but you have to get heart muscle to be able to do that. And these are pretty sick patients, and it was never done. So what relationship does virus have to do with any of that? And the answer is that COXSACKIE virus specifically has a series of proteins, proteases, within it, in particular protease 2A, which actually specifically cleaves dystrophin right in the middle here, giving you an acquired form of dystrophin disease and a dilated cardiomyopathy. This is not genetic based, and so it's recoverable. So if you put this patient on any heart resting therapy, like an assist device, they get better within several days to a week or 2 weeks. So much faster recovery because of the mechanical unstressing. This is a busy slide that shows some of the various pathways involved. So at the molecular level, a lot of studies have been done. Here's that protease 2A, but there are lots of other players in here, including the cytokines and how these all get triggered. The only reason I showed this to you is simply to say that we have targets for therapy. And those targets are being worked on one by one because at the end of the day, steroids doesn't really work. And then ischemia, the parvovirus, and this is where the endothelium comes into play. So let's look at outcomes. So this is inflammatory heart disease, viral type. So you get viral infection in the heart, you get acute viral cardiomyopathy, turns into chronic disease, and you end up with a dilated heart, dilated dysfunctional heart, and cardiomyopathy. They get transplanted. They get viral infection because now they're immunocompromised, and they get either acute graft rejection or chronic graft rejection, which includes coronary disease, and that's their end game of ischemic cardiomyopathy, and they end up either needing a retransplant or they die because of graft loss. So we thought that this might be a group of patients, as I mentioned. It may help us understand a little bit about the cardiomyopathy patients. And here, so this particular study was done in the 90s. We published this in the New England Journal. And this, so this was the 90s, so the adenoviral era. These patients all came blinded to us from Loma Linda Children's Hospital, where they were doing all of these neonatal transplants. And they would send us in bulk all of these biopsies that were frozen, and we would blindly do them. And at the end of a 5-year period, we sent it back to them, the results. At that point, they unblinded the clinical features of these patients and reported it back to us, and then we reported it in the paper. So you could see that 8 or 9% of the biopsies were positive, mostly adenovirus, a little bit of enterovirus, a few parvos. Rejection was in 35 of the 48 positive cases, so not a complete correlation, but pretty reasonable. And then the virus associated with graft rejection, mostly adenovirus. So we wanted to know if that meant anything, so we did a Kaplan-Meier survival curve, and here's that survival curve. So what I'm depicting here is the months after transplantation and the probability of graft survival. And what you can see here is if you never had a PCR positive result, you had a 95% 5-year survival. Pretty darn good for a post-op transplant patient. If, on the other hand, you were PCR positive, you had a steep decline. So viral negative, 96% survival at 5 years, viral positive, 65%. Now, I should mention one feature that isn't mentioned here, and that is that 100% of these patients were treated with steroids after the biopsy because they all had rejection, and they ended up not getting better and going on to lose their graft and not surviving. So we then wanted to ask the question of, okay, if steroids don't work, what does? And we hypothesized at that point that IVIG, immunoglobulin, would work, but for different reasons that other people were hypothesizing. Most people were thinking that it was going to be good for immunomodulation, which it's thought to be. I thought it was going to work because of the population dynamics. So if every 10 years we have a different virus that's the risky virus, That means that the population has a lot of that virus in the population, so that the IVIG, regular IVIG, would have high titer of that specific virus, and that it would be a specific antiviral therapy, like a vaccine, only different. And so we did this study, and we started this study in the beginning of the decade of the 2000s, which was still the end of the adenoviral era, thinking that it was going to be a replication of the previous study. To our unhappy surprise, it was a different era and a different virus. So about the same percentage of positive, about 40%. The other was 38%. This is 39%. And here's viral negative. And you can see that parvovirus was the key player in this regard. When you look at graft survival in the PCR negative versus positive, you see a similar difference. It's from a p-value substantially different. You can see the 5-year probability if you're PCR negative, not as good as the previous, but 86%, post back down to 60+%. So a substantial difference in the PCR positive versus PCR negative. The difference here versus the adenoviral positive patients was this was really all based on advanced transplant coronary artery disease, so coronary obstructive disease. And you can see, again, the PCR positive versus negative, 5-year survival 97% if you're negative, 60% if you're positive. So substantial different reason for the loss of your graft, but at the same rate, essentially, as previously. So looking at the different viruses, you see that adenovirus, ugly player, EBV, not so good. Parvovirus, on the other hand, very good. But there's a reason for that, and that is that we treated those patients with a different agent. So here's in the 2000s, freedom from advanced coronary disease. You can see your parvoviral negative, your parvoviral acute positive, and then chronic disease negative. And so this time scale you can see is much different. 97, 98%, 5 years free of transplant coronary disease. Acute cases, 77%, chronic down to 50%. So you have gradual loss as each year goes along that you've been post-positive PCR. And this just demonstrates the difference in immunohistopathology in these particular patients by a different author group from Germany. These are other Kaplan-Meier survival curves demonstrating something similar. And another one demonstrating the same kind of findings where you have viral positive versus viral negative. And this was another study out of our group in Houston at the time. So ventricular remodeling and survival are more favorable for myocarditis than idiopathic cardiomyopathy, but you can see why. One is a built-in problem of genetics, and the other is an acquired problem. But people weren't really aware of that in the pediatric age range. Our thought was that everybody died. This is a study from our pediatric cardiomyopathy registry, the PCMR, that's been NIH funded for the last 20 years or so. And again, you can see that the biopsy-confirmed versus the idiopathics, of which a high percentage are genetic, there's substantial difference. So from a therapy standpoint, in our view, first-line therapy is supportive care, so you need to be ventilated if you're in trouble. Heart failure, diuretics are key in these patients. Inotropes, we don't use the usual inotropes in these patients. We don't use dopamine, dobutamine, epi, norepi. We use milrinone and calcium plus or minus vasopressin to get them over the hump and not have a very high mechanical stress. Or we put a mechanical device in, a ventricular assist device. Monitor for arrhythmias and treat it if you have them, because this is a pretty irritable myocardium. And then steroids are the mainstay still, but we use IVIG frequently. Some people use interferon, particularly in Germany, or other immunosuppressive meds. And the reason behind all of these is demonstrated here. You can either use medications that fight against viral entry. So viral receptor antagonists or antiviral vaccines would theoretically stop the heart from allowing the viruses to get in. The problem with that is that you're making the diagnosis after the virus is already in. And so a little bit too little, too late kind of a scenario. The next target is viral replication. This is where interferon and ganciclovir would come into play for CMV and for any of the others. Or you can target the late phase, which is immunosuppression for inflammation or immunoabsorption at that phase. And these are the various drugs, including IVIG, which is both good for viral replication and inflammation. And as I mentioned, in my view, very target specific from the viral standpoint. So interferon beta treatment, and this is from colleagues in Germany, elimination of certain viral genomes and improved LV function has been demonstrated. High dose IVIG have been shown to have improved LV function, but this is in cases of parvo and adenovirus, and then immunosuppression, Imuran and prednisone, but as a general statement, a very small select population will respond positively to that. So your RNA viruses, in particular the COXSACKIE viruses, interferons work pretty well for those, plus or minus IVIG. For hepatitis C, which we don't see much in the US, interferon alpha. And in the DNA viruses, specifically adeno and parvo, you see that IVIG works. Just so happens that when we did these studies, adenovirus and parvovirus were the key players. So I don't have any data on the interferons because we've never had to use them. So when we studied this, this group of patients in this publication, we had a total cohort of 94 transplant patients. 37 or 39% were positive, 61% negative. Half and half essentially treated with IVIG plus steroids. This group just steroid treated. It was non-randomized. Some of it was controlled, so it was an imperfect study, but it's what we had. And here are some of the findings. So this is the effect of IVIG plus steroids versus just steroids. And what you see here is the IVIG-treated patients versus the IVIG untreated patient. And what you can see basically is that the IVIG-treated patients is basically as if they were never infected, versus the steroid patients, which did as bad or worse as the patients that I showed you earlier that just received steroids in that other group. When you look at advanced transplant coronary disease, same kind of outcome, treated versus untreated. Again, an 82% freedom at 3 years versus 44% if just getting steroids. When you look at the overall freedom from advanced transplant coronary disease and the positive versus negative versus IVIG treated group, you can see here PCR positive, IVIG treated. You can see the PCR positive, the PCR negative in green here. So they're nearly overlapping. And in fact, the treated patients seem to do better over the long haul than even the PCR negative, although it's not really statistically significant. And then the PCR positive steroid treated patients do much worse than all of the above. So I would glean from this personally that IVIG plus steroids works. We never had the nerve to not give them steroids, so I don't know what use steroids is in that particular scenario. This is, was focused more on the use of ventricular assist devices, and you can see the outcome and what we did here. But you can see that a lot of these patients actually recover. Some ended up with destination therapy or long-term devices and then went on to get transplanted. But the outcomes still are much better than non-treated or just steroid-treated patients. So, long-winded approach to coming to a conclusion, which is viral inflammatory disease. And in my view, we're talking about myocarditis and transplant rejection. But it may be other infections may be the same. We've just never studied it. It's commonly a pretty bad outcome, particularly with the acute onset patients. If you get them over the hump, they do extremely well. If they become chronic, then they go on to get transplanted. there's this shifting demographic of virus that causes these diseases, which makes long-term therapies difficult to consider. And so novel therapies, and I think IVIG could be one of them for novel reason, not that it's a novel therapy. And then the point of the clinical people and research teams getting together to collaborate on these clinical questions is really pretty critical and underutilized. And I happen to bridge between the clinical and the research lab, and so we're able to do it. Most places can't really achieve that, but it's really important. These are all the people who did all the work. I just take the credit for it, which is great. I'm happy to answer any questions.
It's quite clear that you use IVIG and steroids in the transplant market. How about clearly viral? You're sure it's a viral?
I use the same, and it's the same kind of outcomes. In fact, it's better. If you use IVIG plus steroids, that's our first therapy plus the milrinone approach. If we're not really making a difference in the short run and the patient's progressing, we'll put them on an assist device, and then they get better. Not all, but mostly all. But you have to get them at the right time. If you get them, lingering at some other place and then they come to you late, that's a different scenario. That's more difficult. But acute onset disease treated acutely, they almost always survive. In fact, the more inflamed they are, the better the outcome. So these fulminant myocarditis cases do better than any of the other cases. You just got to get them over the hump and reduce mechanical stress.
How high did you say the IVIG dose was?
We use the same dose as COXSACKIE treatment, so 2 grams per kilo. We tend to do it, IVIG is a lot of volume. So we tend to do it over somewhere like 24 to 36 hours because they can't afford the volume load.
So, first of all, thank you. This has been an excellent discussion. Myocarditis is one of those very feared diagnoses in the emergency department. That they can look very similar to a viral illness, especially in the middle of the period, and then 48 hours later, they're in full rest. So, any thoughts, tips on the most sensitive and/or specific clinical indications early on that this could be moving into pulmonary?
Yeah, so it's a hard question in that it depends on where in the course you catch them. So if you catch them really early, they have no features other than viral illness. If you catch them towards the end of being not cardiac symptomatic, but they actually have physical exam features, then you're going to hear a gallop, you're going to have sinus tachycardia, you might or might not have an enlarging liver, but not gigantic. And then the next phase is they get dyspneic, they get a big liver, they have full-blown disease. The other thing is that in the younger kids, there is one thing that differentiates pneumonitis or pneumonia from heart failure. There are a couple of things. One, on a physical exam, is that little kids with heart failure don't have crackles. Pneumonia patients always have crackles. So if you hear crackles, it's pneumonia, period. Almost never is it going to be a cardiomyopathy, heart failure, unless it's a pneumonia-induced. So you still have to look at the heart, but you got to be thinking this is going to be a pneumonia. And then you could prove it by sending off a brain natriuretic peptide, a BNP, and that's actually was a study done in EDs, adult EDs, where they looked for heart failure patients versus respiratory failure patients, and they found that BNP was only positive in heart failure and never positive in pneumonia patients. It's called the RALES trial, R-A-L-E-S, takeoff on RALES. And so it's a good biomarker for differentiating, but you got to wait. Even though it's a point of service testing in many places, it's going to take you an hour or more to get a result, maybe longer, in which case that patient may be transitioning to bad, and then you're behind the 8 ball. But a quick physical exam, I mean, you're going to hear crackles, right, if they're there. And if they are, then you want to see if there's pneumonia on X-ray, but you may or may not see it because they're going to be dry because they're sick. And, so, but it will help you hesitate or not to give fluid boluses. And we talked a little bit about this last night, because our patients get sicker faster by going through the ED because you're treating it like all the other septic patients that come in, which is appropriate, but if they have heart failure, they get into trouble much faster. And that would mitigate the quick move to bolus fluid. So worth looking at those things.
What's your indication for biopsy? Maybe I'm missing the presentation. When do you do biopsy? Is it standard?
So in pediatric cardiology, in most places, the indication is that you're a post-op transplant patient. In other words, we really don't do biopsies very much, which is part of the problem, because I can't do this. You know, you can't use it as a biomarker if you don't have a sample. And peripheral PCR doesn't tell what's going on in the heart, because some of the nucleic acid lingers for a period of time. So the problem becomes that the heart muscle is thin-walled and mushy because of all the inflammation. And unless you've done a lot of this, it's easy to perforate the heart, very easy to perforate the heart. The good news is in pediatrics, we don't do LV biopsies very often. And usually the RV is less affected, which is usually where we do our biopsies. But nonetheless, we don't do so many biopsies in pediatrics that people feel comfortable doing it. So for sure, in the little kids, we never do it. In the bigger kids, it depends on your institution and the comfort zone of the people who would be doing the biopsies. So rare indication, basically.
There was a time when it was thought that PCR of tracheal aspirin would correlate well.
Right.
Like biopsy.
Right. So I actually wrote that paper. Yeah. So that was in the that was in the adenoviral era, and it was only tracheal aspirin and biopsy that were correlating. Blood was negative. Everything else was negative, and non-correlating. So we were using that in the 90s, but you know it stopped working after a while, and we wondered why. And then, oops, parvovirus became the major player, just sort of out of the blue. So we don't use that at all anymore. Probably get back to it somewhere along the way, but yeah.
So I still remember.
Exactly.
Thank you for the presentation, Dr. Towbin. Do you look at Parvo PCR in the kids that present with Kawasaki, or the ones that had Parvo positive PCR in myocarditis? Did they have features of Kawasaki?
So as a general statement, we almost never see those patients unless they have, big coronaries, which is, not very common. And none of those kids really get biopsied when it comes right down to it. If they may or may not go to the cath lab. If they go to the cath lab, it's really to shoot their coronaries, and measure a little bit of the pressures. But so we don't really get to test those patients. In the parvo-positive cases that don't have any features of Kawasaki, it would be a rare event for us to see coronary abnormalities. That doesn't say they don't have Kawasaki. It just isn't the usual presentation. So the shorter answer is I don't know.
Because one of the most important differences you've seen with the Parvo PCR cases, Parvo-positive PCR cases, were the fact that the inflammation was induced mostly by ischemia.
Right. Yeah. So it's coronary insufficiency instead of dilation of the coronaries that you end up seeing. So, and the coronaries are not obviously abnormal when you look at it because it's inside instead of outside. So you see what appears on an echo to be normal coronaries, but if you do any specific coronary study, be it an autopsy or an angiogram or an ultrasound of the coronaries, specifically, you'll see the inflammation, but not on a regular echo. And most people, when they're sick like that, are not going to go for an MRI or a CT scan. Any other questions? If not, thank you.